Bone and calcium metabolism. Calcium is a divalent cation. 98% of the calcium in the body is in bone, and less than 1% of total body calcium is present in blood. Half of this is free or ionized. The remainder, about 40%, is protein bound, mainly to albumin, or complexed with other ions such as lactate, bicarbonate, and phosphates. A small proportion of calcium in the bone can be readily released into the extracellular fluid depending on metabolic circumstances and hormonal factors. In the kidney, most calcium is passively reabsorbed. Some calcium is actively reabsorbed under the influence of parathyroid hormone, activated vitamin D, calcitonin, androgens, and estrogens. In gastrointestinal tract, calcium is absorbed and secreted. Around 600 mg per day is secreted in digestive juices and 100 mg per day is excreted in feces. Calcium is mostly absorbed in duodenum and upper jejunum and is enhanced by a high oral intake of calcium and an abundance of activated vitamin D. In the body, calcium is required for the structural role of skeleton, nerve conduction, muscle contraction, and intracellular signaling in neuroendocrine secretion, cell metabolism, and growth. The main hormones involved in calcium homeostasis are parathyroid hormone and 1,25-hydroxy vitamin D, also known as activated vitamin D. Parathyroid hormone is produced in parathyroid glands and is produced and released in response to a low extracellular calcium concentration or a high extracellular phosphate concentration. High calcium levels inhibit parathyroid hormone secretion and promote its metabolism and excretion. Hypomagnesemia also reduces parathyroid hormone production. Actions of parathyroid hormone include direct effect on the bone, direct effect on the kidney, and indirect effect on the gut. Direct effect on the bone. Parathyroid hormone stimulate bone resorption or bone formation depending on its concentration. Prolonged exposure to higher concentrations of parathyroid hormone favors bone resorption, which results in a high turnover bone disease and causes bone pain and increased fracture risk, as seen in osteitis fibrosa cystica. Adynamic or low turnover bone disease is associated with a low or normal parathyroid hormone levels, which may be a result of treatment, and decreased bone resorption and formation. Direct effect on the kidney. Parathyroid hormone increases the 1-alpha hydroxylation of vitamin D to create more activated 1,25-hydroxy vitamin D, increases reabsorption of calcium in the distal convoluted tubule, promotes excretion of phosphate by reducing reabsorption in the proximal tubule. Indirect effect on the gut is by increasing the amount of activated vitamin D. High parathyroid hormone levels may also cause left ventricular hypertrophy, cardiac fibrosis, and peripheral neuropathy. In chronic kidney disease, hyperparathyroidism along with poor control of serum phosphate and calcium phosphate products are associated with increased cardiovascular disease risk and vascular calcification. These are also risk factors for development of calcific uremic arteriolopathy or calciphylaxis, which is a painful ulcerating skin condition which carries a high mortality. The other important hormone is 1,25-hydroxyvitamin D or activated vitamin D. 1,25-hydroxyvitamin D is made from vitamin D, which is D2 or ergocalciferol, or D3 or cholecalciferol forms, which is made in the skin following exposure to UVB sunlight, as in D3, or obtained through the diet or supplementation, which can be both D2 or D3 forms. Vitamin D is relatively inactive. Both vitamin D2 and D3 bind blood vitamin D binding proteins and undergo 25-hydroxylation in the liver and 1-alpha hydroxylation in the kidney to produce the activated form, which is 1,25-hydroxyvitamin D. The rate limiting step is 1-alpha hydroxylation by the enzyme 1-alpha hydroxylase. The activity of this enzyme is subject to multiple homeostatic controls, which include increased activity by parathyroid hormone and hypophosphatemia and indirectly by hypocalcemia, decreased activity by hypercalcemia, hyperphosphatemia, high levels of 1-alpha hydroxylase and fibroblast growth factor 23 or FGF23. Vitamin D therefore reduces its own production via negative feedback. 1,25-hydroxyvitamin D has a direct action on gastrointestinal tract, which includes multiple actions on different proteins, serve to increase absorption of calcium and phosphate. On kidney, by inhibiting its own synthesis by reduced 1-alpha hydroxylase activity. On parathyroid glands, by inhibiting parathyroid hormone synthesis. On bone, at high concentrations, activated vitamin D increases osteoclastic activity and promotes bone resorption. Hypercalcemia. Hypercalcemia with a serum calcium concentration of more than 10.5 mg per deciliter is common. Adjusted calcium concentration 10.5 to 12 mg per deciliter is often asymptomatic. Adjusted calcium concentration of more than 12 mg per deciliter usually causes symptoms including malaise, polyuria, polydipsia, nocturia, renal calculi, bone pain, abdominal pain, nausea, constipation, and dehydration, low mood, and confusion. Adjusted calcium concentration of more than 15 mg per deciliter carries a risk of arrhythmias. Measured calcium levels are corrected for albumin using the following equation. Corrected calcium equals 0.8 multiplied by 4 minus patient's albumin in gram per deciliter plus measured serum calcium. Low adjusted calcium may be found in patients with severe hypoalbuminemia, while true ionized calcium levels are normal. This reflects a nonlinear relationship once the albumin levels falls below 2 to 2.5 gram per deciliter, such as in patients with chronic liver disease, nephrotic syndrome, heart failure, and malnutrition. Causes of hypercalcemia include primary and tertiary hyperparathyroidism. Primary hyperparathyroidism, characterized by high corrected serum and urine calcium and low serum phosphate, increased parathyroid hormone due to parathyroid adenoma or hyperplasia, 80% of which are due to benign solitary adenoma. Multiple endocrine neoplasias type 1 and 2A account for 2% of all such cases. Patients presenting with hyperparathyroidism aged less than 40 years should therefore be screened for multiple endocrine neoplasias. Tertiary hyperparathyroidism is autonomous secretion with high parathyroid hormone despite hypercalcemia. Note that secondary hyperparathyroidism does not cause hypercalcemia but is characterized by increased parathyroid hormone in response to hypocalcemia with low active vitamin D levels because of renal disease or dietary deficiency. Other causes include malignancy. Hypercalcemia occurs in up to 30% of all cancers, with lung cancer, breast cancer, and myeloma being the most frequent causes. Two main mechanisms include cytokine release, which activates osteoclasts with osteolytic bony metastasis in advanced breast carcinoma and hematological malignancies such as multiple myeloma. Production of parathyroid-related peptide or calcitriol by the tumor, example, squamous cell lung cancer, breast cancer, and renal cell carcinoma. Thyrotoxicosis results in excessive production of thyroid hormones causing bone resorption, release of calcium into the extracellular fluid. Hypoadrenalism resulting in glucocorticoid deficiency stimulates hypercalcemia. Although the mechanism is not fully known, it is probably due to reduced renal calcium excretion and increased calcium resorption from the bone. Thiazide diuretics reduce calcium excretion from the kidneys. Immobility causes increased bone resorption. Iatrogenic causes are due to hypervitaminosis D and excess calcium supplementation. A rarer cause is familial hypocalciuric hypercalcemia, which is a rare autosomal dominant condition resulting from inactivating mutations affecting the calcium sensing receptor gene, leading to calcium hyposensitivity. It is characterized by low urinary calcium of less than 200 mg per day and urinary calcium creatinine ratio of less than 0.01. Sarcoidosis involves extrarenal production of activated vitamin D, which causes hypercalcemia. Milk alkali syndrome results from excessive ingestion of calcium and alkali salts in antacid preparations. Approach includes history to exclude iatrogenic causes and immobility, examination to look for signs of malignancy, blood tests such as urea and electrolytes, calcium, parathyroid hormone, and vitamin D levels, phosphate and magnesium to exclude renal impairment. Urine tests for calcium and calcium creatinine ratio to exclude familial hypocalciuric hypercalcemia, X-rays to look for characteristic subperiosteal resorption of distal phalanges, tapering of distal clavicle, and salt and pepper pot skull lucencies and brown tumors of long bones. If parathyroid levels are appropriately suppressed in the face of a normal parathyroid axis, check the thyroid stimulating hormone, protein electrophoresis, and urine Bence-Jones proteins and consider a synacthin test. Parathyroid technetium 99M technetium sesame B scan to identify parathyroid adenomas in primary hyperthyroidism can be considered. Dual energy X-ray absorptiometry or DEXA scan to look for evidence of resulting osteoporosis. Treatment. Mild asymptomatic hypercalcemia does not always need treatment. Such patients should be monitored at intervals and advised to maintain hydration to reduce the risk of renal stones. Moderate or severe degrees of hypercalcemia are often associated with significant dehydration. Prompt fluid resuscitation can cause a marked improvement in serum calcium concentration. A loop diuretic such as furosemide can be given to promote calcium excretion, but only after adequate fluid resuscitation has been done. Primary hyperparathyroidism has a long-term effect on osteoporosis and renal calculi. Surgical resection of the parathyroid lesion is indicated if an adenoma is identified in primary or tertiary hyperparathyroidism. Cinacalcet, which is a calcium sensing receptor agonist which acts on the parathyroid cells where it mimics the effects of hypercalcemia and further suppresses the parathyroid hormone synthesis and secretion, can be used. It may be prescribed in those with tertiary hyperparathyroidism due to chronic kidney disease and primary hyperparathyroidism who are unsuitable for surgery and hypercalcemia from malignancy not responding to treatment. The combined use of vitamin D and calcium mimetics has reduced the need for parathyroidectomy in management of renal bone disease. Glucocorticoids can be useful in hypercalcemia caused by malignancy, sarcoidosis, vitamin D toxicity. Bisphosphonates inhibit osteoclastic activity and prevent calcium release from the bone. Intravenous pamidronate is commonly used in emergencies. Patients with chronic severe hypercalcemia may benefit from a bisphosphonate with a longer half-life. For example, risedronate or zoledronic acid. Hypocalcemia. Hypocalcemia with a serum calcium level less than 8.5 mg per deciliter is common. Adjusted calcium concentration of 8 to 8.5 mg per deciliter is often asymptomatic. Adjusted calcium concentration of less than 8 mg per deciliter may cause symptoms of neuromuscular excitability, tetany, and paresthesia of extremities and perioral area, along with cramps and tetany. Trousseau and Chopstick signs may be demonstrated. Adjusted calcium concentration of less than 7.5 mg per deciliter may result in arrhythmias or seizures, especially with a rapid fall in serum calcium. Causes of hypocalcemia can be remembered by a mnemonic: low calcium. Lysis syndromes, including rhabdomyolysis and tumor lysis syndrome, with widespread release of phosphate from damaged cells binding to calcium and lowering the serum levels. Osteoblastic metastasis with calcium uptake, example from prostate, breast or bladder cancers, with infusion of citrate-containing blood products that can cause pronounced hypocalcemia due to citrate complexing with calcium. Congenital disorders, example DiGeorge syndrome, caused by deletion of a small segment of chromosome 22. Acute pancreatitis, where low calcium is a marker of severity. Long-standing inadequate dietary calcium or poor absorption of dietary calcium due to gut disorders. Chronic kidney disease with reduced renal hydroxylation of vitamin D leading to lack of active vitamin D. Iatrogenic causes including prolonged use of loop diuretics or bisphosphonates. Underactivity of parathyroid hormone and vitamin D axis including hypoparathyroidism, pseudohypoparathyroidism, and vitamin D deficiency. Approach to hypocalcemia include the history to look for chronic kidney disease, long-standing hypertension, diabetes mellitus, malabsorption, and family history. Examination to look for signs of malignancy, malabsorption or gut disorders. Blood tests for calcium include parathyroid hormone levels, vitamin D levels, phosphate, magnesium, urea, creatinine, liver function tests, and creatinine kinase may be elevated, ideally before the treatment commences. Parathyroid hormone levels should be increased if the parathyroid hormone axis is working normally. If parathyroid hormone levels are low or inappropriately normal, primary hypoparathyroidism should be considered. Urine calcium and phosphate excretion, imaging to exclude growth plate abnormalities in children, pseudofractures, also known as Looser's zone. Treatment. Treat the underlying cause of hypocalcemia wherever possible, providing calcium supplementation with an uncorrected deficiency of magnesium and vitamin D will provide only short-term benefit. Mild hypocalcemia does not always need treatment. Moderate hypocalcemia of less than 8 mg per deciliter or mild symptomatic hypocalcemia can be treated with oral calcium salts. More significant degrees of hypocalcemia of less than 7.5 mg per deciliter should be considered for intravenous calcium gluconate correction with ECG monitoring. Once serum calcium levels have normalized, patients may be switched to oral calcium and vitamin D. Vitamin D replacement. Less than 10 nanogram per ml, patients need to be loaded with cholecalciferol to provide a total of 3 lakh units of vitamin D over 6 to 8 weeks, followed by daily supplements. Vitamin D levels of 10 to 20 nanogram per ml should be treated with 1000 to 2000 international units of cholecalciferol daily. Additional calcium only is required when malabsorption or inadequate oral intake is seen. Active vitamin D, most commonly with 1-alpha hydroxylated vitamin D or alpha calcidiol, is used in chronic kidney disease. This corrects hypocalcemia and suppresses parathyroid hormone synthesis and secretion. Phosphate and calcitriol replacement is needed in hypophosphatemic ricket patients. And lastly, tumors must be resected in oncogenic osteomalacia. Thank you for watching, and please share and subscribe to the channel for medical lectures.